It's my sincere pleasure today to be with a wonderful group of panelists regarding review of some GI cancer cases. My name is Dr. Kathy Ng from Vanderbilt Ingram Cancer Center, the David H. Johnson Endowed Chair in Surgical and Medical Oncology, and the co-director of the GI Research Program. Today we have some wonderful panelists, and we'll just go around and have them introduce themselves. So please introduce yourself, Carrie Siegel.
Hi, good afternoon. My name is Dr. Carrie Siegel. I'm an abdominal imaging radiologist at Washington University in St. Louis.
Hello, everyone. My name is Al Benson. I'm a GI medical oncologist at Northwestern University and the Robert H. Lurie Comprehensive Cancer Center, where I serve as one of the associate directors.
I am at Emory University and Winship Cancer Institute. My focus is primarily complex upper gastrointestinal and hepatobiliary surgery, and it's a pleasure to be here today.
I'm Preetesh Patel. I'm an associate professor of radiation oncology at Emory University. I work closely with Dr. Kubi. Glad to be here today and to discuss some good cases.
This is a 39-year-old female with newly diagnosed stage 3B, MSI stable, rectosigmoid adenocarcinoma. I believe it's more rectal, if I'm correct, with suspected involvement of the anterior mesiorectal fascia on pelvic MRI. She presented with rectal bleeding and alternating diarrhea and constipation for several months, and her ECOG performance status is 0. Medical history is non-contributory, the social history is non-contributory, and the family history is only significant in regards to maternal grandmother who had colon cancer in her 70s. So a little bit older than the average age patient in the United States. In February of this year, she had a colonoscopy with a partially obstructing tumor consistent with a moderately differentiated adenocarcinoma, MSI stable. Her CEA is 9. Your CT scan of the chest, abdomen, and pelvis reportedly demonstrates no evidence of distant metastatic disease. Dr. Siegel, do you care to comment about this imaging?
Sure. On the bottom image, we have a post-contrast dynamic CT through the pelvis. And the top image is the high B value diffusion imaging, which I alluded to earlier. Now, if you look at the bottom image below the uterus or behind the uterus, there's a mass associated with the rectum with a breach of the serosa at about the 1 to the 3 o'clock position. There's also multiple small nodes in that region. The criteria that we use for abnormal nodes are any nodes greater than 9 millimeters are considered positive. Nodes that are between 5 and 9 millimeters have to meet 2 of the 3 criteria of an indistinct margin, a heterogeneous internal architecture, or round. And lymph nodes less than 5 millimeters have to have all 3 of those criteria. Every once in a while, we'll see a whole group of lymph nodes coalesce together that don't exactly meet the criteria. And usually what we'll do is we'll mention it in our dictation that these don't meet criteria, but that they should be examined on follow-up exam. And we're sort of alerting people to keep an eye on it.
Thank you. So I just want to highlight, this is a 39-year-old female, and the average age patient is 67 in the United States. And so given that it is Colorectal Cancer Awareness Month, I think we do want to make sure that people understand that patients can present with symptoms that are suggestive of colorectal carcinoma at a much younger age than expected. And these are some of the symptoms that they present with, and that should guide people to get screened with a new screening age of 45. So I would love to get the input of our multidisciplinary team regarding this patient. So starting with Dr. Kubi.
Yeah, thank you, Dr. Ng. You know, I think the first thing to sort out with this particular patient is how bad her symptoms are before getting on board with neoadjuvant therapy to see whether a role for pre-therapy diversion would be necessary. If the patient can be on a liquid diet and started on therapy, then her symptoms may actually resolve without requiring diversion. But that's one of those scenarios where you actually have to meet the patient and really take a very good history.
Dr. Benson?
So certainly this is exactly a case that needs an expert multidisciplinary team review before any intervention is undertaken. Your point about young people, Dr. Eng, is critical with the rising incidence of colorectal cancer, particularly rectal cancer in our younger population of patients, means that we really have to take any suspicious symptom in a younger person seriously. Even if this patient has a microsatellite stable tumor, we generally recommend genetic counseling because of her age, and it does affect screening recommendations, for example, the patient's brothers and sisters, parents, and so forth. This field of neoadjuvant therapy is certainly rapidly evolving, and we're moving more and more to the concept of giving total neoadjuvant therapy. It's also interesting where we're looking at the location of the tumor. So if I read this correctly, this tumor was at least 10 centimeters from the anal verge. And the recently accrued prospect study in the cooperative group system was looking at patients with more proximal tumors. And there's a question, for example, is neoadjuvant chemotherapy sufficient for these individuals? I think still many people are considering either a sequence of chemotherapy followed by radiation or radiation followed by chemotherapy. And we're also looking for patients with complete response who may not go to surgery. So there's, in fact, Dr. Patel, I'm sure, will comment on short course versus long course radiation. But nonetheless, in a multidisciplinary team review, this would be the discussion about what sequence, what strategy of chemotherapy, chemoradiation for the individual should be taken prior to surgery.
Thank you so much. Now, Dr. Patel, can you comment on the sequencing? You would prefer the chemoradiation therapy first, followed by systemic, or just the reverse in this case? And then as Dr. Benson mentioned, how do you decide which patients you prefer for short course given the RAPIDO data versus long course? And then I'm going to ask Dr. Kubi about, this is a young patient, what about that watch and wait concept? So let's go to Dr. Patel first.
Yeah, no, thank you. I can't emphasize enough, I think, that the issue of younger and younger age with diagnosis of colorectal cancer. Something that comes up that hasn't come up a lot for me as a radiation oncologist with younger patients is fertility. So with this young female patient, I think that's something, we'd want to have that discussion. And it's challenging, of course, because if there is a desire for fertility preservation or egg harvest, we've got to move quickly. We've got to have a multidisciplinary team that understands, the sort of that we're under the gun. And so that's been a challenge in cases where we've desired fertility preservation or egg harvest. And in those cases, the ovaries change dramatically, and that, of course, might influence the decision of the timing and the sequence of the therapy, as you've mentioned. So that's something that sometimes now comes up that didn't in the past. So this is a fascinating area now with a lot of new data to help guide us. I would say with a threatened circumferential resection margin, that often at our institution, it means that we're going to include radiation in the neoadjuvant therapy at some point. And I totally agree, Dr. Benson, that for the vast majority of patients now, we are doing total neoadjuvant therapy with all the systemic therapy and the chemoradiation up front. The German AIO 12 study was a study that compared really giving the chemoradiation first or giving the chemoradiation after the neoadjuvant chemotherapy. And we seem to see that if you give the radiation first, and then the effect of that really is to delay the time to surgery, we tend to get better pathologic response. And so we've seen that in the German study, and then in the study that you just mentioned, Dr. Rang, the RAPIDO trial, a similar finding in that short course radiation was given followed by systemic therapy, and that was compared to a standard chemoradiation and then right into surgery. And so my takeaway there is that delay to getting to surgery is really what's giving us time to see the better responses. And so at our institution, when we really are pushing for the optimal response in the tumor, for instance, if not in this case, but another case for a distal tumor where you're worried about maybe the need for APR, that tends to drive the decision to give the radiation first. In cases where we're much more worried about, for example, significant nodal disease and the risk of micrometastatic disease, in that case, we may choose to do the chemotherapy first. And also in the upper tumors, as Dr. Benson mentioned, there's the possibility that maybe a remarkable response could lead you to then choose not to do radiation, and that may be attractive in a young patient as well. So you know, a lot of considerations. In general, with a threatened circumferential resection margin, like in this case, I would prefer a maximal response, and that typically means chemoradiation first. And to touch on the short course versus long course debate, I think at this point, we've got ample evidence that short course radiation is safe, is effective, and really could be used in any case where you might consider long course radiation. So, you know, it tends to be institutional. At our institution, we're more often doing long course. Dr. Siegel's institution, I think, is almost exclusively doing short course. And I think both are totally standard options at this point. And so whatever the team, the multidisciplinary team is most comfortable with would be the best approach.
Thank you so much. Dr. Kubi, I'd love to get your input about the time frame for surgical resection following completion of TNT approach, presuming the patient received long course, and then also get your viewpoint on your thoughts. You know, we're seeing more young patients now with rectal carcinoma. How are you looking at watch and wait at your institution as a new approach?
Yeah, so this is something we discuss frequently in our tumor board, you know, with Dr. Patel. And in terms of timing of a surgical intervention, you know, probably no sooner than 6 weeks after a completion of radiation therapy. Sort of that 6 to 12 week range has been the ideal sort of time period, but even waiting a little longer is probably thought not to be detrimental to these patients. Now, the discussion about a watch and wait approach, this was originally sort of described or proposed in the early 2000s by Dr. Happel-Gamma. And I think the initial trial showed only a 5% or less than 5% local recurrence rate with just total neoadjuvant therapy and no surgery. And if you follow these patients and they do recur, then coming back and doing salvage therapy is thought to provide sort of the same survival as if you had done the initial resection. Now, several studies have been performed that have not replicated those data exactly, and there are prospective trials that are actually underway. But if this patient had that type of great response, then they would be potentially a candidate to be put in a watch and wait approach.
Thank you so much. It's a great discussion. So now we're going to change the scenario a bit. We have a male patient, young, 38, newly diagnosed, T4N1M0, mid to upper rectum, MSI stable, all RAS wild type. And now we have some new imaging. Dr. Siegel, can you please comment?
Sure. On the left, we have a sagittal high-res T2, and on the right, we have a axial T2. And you can see that there's just a very large mass involving a little bit of the mid-rectum, the upper rectum, and extending into the sigmoid colon. On the axial view, you can see how it's involving much of that sort of anterior wall that's very lobulated, and there's adjacent thickening and irregularity of the left posterior bladder wall, likely related to tumor invasion.
Thank you. So here in this case, with more extensive involvement for T4 disease, Dr. Benson and Dr. Patel, how would you like to proceed with this patient in that sense?
So I think if I saw this correctly, it's a more proximal tumor, but I think at my center, we would favor with a total neoadjuvant approach, the use of radiation followed by chemotherapy. I think that's most likely.
Yeah, I agree. You know, we've treated these definitely with total neoadjuvant therapy. This case is a little tricky. The sigmoid rectosigmoid mass is quite large. So if there were a downstaging effect of induction chemotherapy, that may change the toxicity profile of the radiation. Although I will say it's actually still unclear as to when you're designing radiation, do you use the initial diagnosis MRI or do you use the post-chemotherapy MRI as sort of the gold standard for how to design the fields? That's a question that's really unanswered. But if you have mass effect without clear invasion, you know, that may lead to maybe a slightly smaller radiation field, which in this case, you know, with the risk of bowel toxicity, you may see a change there. The only other comment I'd make here with T4 disease is radiation oncologists now, I think, would consider that non-TME external iliac lymph nodes would be at risk due to involvement of an anterior GU organ like the bladder. And so in these cases, we're typically going forward with elective nodal irradiation that includes the external iliacs, which often then changes the technique from a 3D technique to an IMRT technique if you weren't doing that from the beginning. But more advanced techniques, again, to eliminate or reduce the exposure of the anterior lower abdominal pelvic structures because they're now covering a wider target with the external iliac lymph nodes as well.
Thank you.
Sorry. Dr. I was just going to say, Dr. Patel's comments really emphasizes why initial multidisciplinary team review is so essential, because as he mentioned, if his concern was about the radiation field and really favored chemotherapy first to potentially reduce the radiation field, that would be critical in making a decision as to the sequence. So, this type of planning up front is just so essential so that everyone can raise the pros and cons.
Fully agree. Dr. Kubi, would you like to comment on this patient, this young gentleman with this fairly large tumor that it's involving what potentially could be the bladder and obviously involving the sigmoid colon?
Yeah, thank you. So the thoughts that come across my mind, it looks like it's more the dome of the bladder rather than the trigone, which would be more favorable for being able to preserve some of the bladder after surgery when this patient comes to surgery. But I would need to sit down with Dr. Siegel and see if she agrees with that, and then see what the response is to pre-op therapy. So I think that the thought of an exoneration, would have to be on the radar, but given the location, I think the concern for that would be a little lower. Dr. Siegel, do you have any comments on that?
It does involve the bladder dome, but quite posteriorly, not the cephalad-most aspect of the dome.
Right, so that would require further evaluation and really thorough pelvic or rectal protocol MR after pre-op therapy with cystoscopy and further evaluation.